Minimal change disease. Minimal change disease is the most common cause of nephrotic syndrome in children. It is usually idiopathic but can occasionally be secondary to other conditions, particularly in adults. Secondary causes include drugs, for example NSAIDs, malignancy, for example Hodgkin lymphoma, and autoimmune disease. The name reflects the fact that glomeruli appear normal under light microscopy, with changes only visible on electron microscopy. Peak incidence. Most common in children aged 4 to 8 years old, accounting for 80 to 90% of cases of childhood nephrotic syndrome. Also occurs in adults, responsible for around 10 to 20% of cases of adult nephrotic syndrome. Pathophysiology. Effacement, fusion, of podocyte foot processes seen on electron microscopy. Increased glomerular permeability leads to massive proteinuria and the features of nephrotic syndrome. The precise mechanism is not fully understood, but T-cell dysfunction and abnormal cytokine release are thought to play a role. Symptoms. Symptoms of nephrotic syndrome include edema, periorbital, peripheral, or generalized, foamy urine due to proteinuria, weight gain from fluid retention, and fatigue. Signs. Signs again are those of nephrotic syndrome. Periorbital edema, peripheral edema, ascites or generalized edema in severe cases, and hypertension in some individuals. Diagnosis. Minimal change disease is suspected in children presenting with a triad of edema, hypoalbuminemia, and proteinuria, with or without hyperlipidemia. Investigations include urinalysis. This shows heavy proteinuria, usually without significant hematuria. Urine protein quantification. 24-hour urine protein excretion over 50 mg per kilo per day, or urine protein creatinine ratio over 200 mg per millimole. Serum albumin. Typically less than 30 grams per liter. Lipid profile. This may show hypercholesterolemia and hypertriglyceridemia. Urea and electrolytes. These are often normal, though mild abnormalities may occur. Renal ultrasound. This is normal in minimal change disease and is used to exclude other causes. Chest X-ray. This may be used if respiratory symptoms are present to assess for pneumonia or pleural effusion. Renal biopsy. This is not routinely required in children with typical features, but indicated in adults in atypical presentations or if the patient is steroid resistant. Biopsy shows normal light microscopy with podocyte effacement on electron microscopy. Complications. Relapse. This is common especially in children. Steroid-related adverse effects with long-term or repeated use. Hyperlipidemia. Hypertension in some patients. increased risk of infection due to loss of immunoglobulins and immunosuppression, and thromboembolism due to the hypercoagulable state in nephrotic syndrome. Management. First-line treatment. Oral corticosteroids, prednisolone, are highly effective, with remission achieved in around 80% of children. Supportive management. Sodium and fluid restriction. Albumin infusion with intravenous diuretics, for example furosemide, may be considered in cases of severe edema and hypoalbuminemia. Steroid-resistant or frequently relapsing disease. Corticosteroid-sparing immunosuppressants such as cyclophosphamide, cyclosporin, tacrolimus, or mycophenolate mofetil. High-dose intravenous corticosteroids may also be used in resistant cases. Secondary causes. Management includes treating the underlying condition or discontinuing causative drugs. That was the full video, and there's hundreds more like it waiting for you at finalmed.co.uk. Get over 9,000 UKMLA exam questions, hundreds of animated videos, and our trusted textbook all in one platform designed to make your revision faster, clearer, and exam focused. Start your free 7-day trial today